OsteoSignal Episode 35. This is OsteoSignal with Neal O'Neill, a podcast exploring how osteopathic science can help you decode the body's biomechanical, biochemical, and bioelectrical signals so you can thrive. And now, here's Neal.
Welcome to the OsteoSignal podcast. The immune system has a nervous system. Macrophage myofiber synapses, the OsteoSignal healing loop, and why every manual therapy technique is an immune intervention. Why does motion heal? Not in the vague clinical intuition sense, we all feel that, but mechanistically, what is actually happening at the cellular level when you restore a restricted joint, release a fascial plane, reestablish normal load transfer through a pelvis that has been stuck for months or years? And what is the precise biological chain of events that converts a mechanical input into actual tissue repair? I want to give you an answer today that's more specific than anything in the textbooks, because a piece of research came across my desk recently, and when I read it, I had to sit with it for a minute. It provides direct biological evidence for something the OsteoSignal model has been pointing toward, but that most clinicians have never seen framed this way. The finding: macrophages, the immune cells we were taught are debris clearers and cytokine releasers, form synaptic-like connections with injured muscle fibers. They physically adhere to the damaged cell surface, build a specialized junction that looks like a neuronal synapse, right? How a nerve normally attaches to a muscle, and then drive calcium signals directly into the muscle. And those calcium signals trigger that repair cascade. The immune system is not broadcasting chemical signals into the extracellular space and waiting. It is plugging in directly, electrically, into the tissue it's trying to repair. Welcome back to the OsteoSignal podcast. My name is Neal O'Neill. I'm a clinical osteopathic manual therapist and physical therapist. My work focuses on translating complex physiology, neuroendocrine signaling, biomechanics, immune regulation, and nervous system function into hands-on clinical methods that help restore adaptive capacity in patients. Much of my perspective comes from years of clinical practice combined with training in translational research, where the goal is to bridge the gap between the laboratory sciences and what actually helps people recover function in the clinic. Joining me today is Autumn Mayberry, a fellow osteopathic manual therapist whose work focuses on integrating structural treatment with the body's autonomic, endocrine, and visceral systems. Autumn brings a deep clinical perspective to these discussions and helps ground many of the concepts we talk about in real patient care. Hey, Autumn.
Hey, Neal. Thanks for having me.
And helping guide the conversation, as always, is Brent Mayberry, our podcast facilitator. Brent is an engineer by training, which makes him the perfect person to ask the kinds of questions that many listeners are probably already thinking, helping translate some of the deeper physiological concepts into language that is clear, practical, and understandable. Thanks for joining, Brent.
Hey there.
Okay, without further ado, what macrophages are actually doing? The classical model of macrophages goes like this. Tissues get injured, an alarm signal goes out, macrophages arrive, they eat the debris, they release cytokines, cell signaling chemicals, and eventually the tissue heals. Macrophages as janitors, macrophages as chemical messengers. That's not wrong, but it is dramatically incomplete. You've probably heard of M1 and M2 polarization, the spectrum from pro-inflammatory macrophages to anti-inflammatory regenerative ones. Okay, that's what the M1, M2 polarization is. You have these pro-inflammatory macrophages, which we all know that chronic inflammation is bad for us. And then they turn into these anti-inflammatory regenerative macrophages. M1s produce tumor necrosing factor alpha, interleukin 1 beta, interleukin 6, the inflammatory drivers. M2s produce a whole different class of chemicals, interleukin 10, tumor growth factor beta, growth factors that support tissue rebuilding. In a healthy healing response, there's a transition from M1 to M2 dominance as the injury resolves. The inflammatory phase clears the damage. The regenerative phase rebuilds the architecture. What the new research shows is that this chemical signaling model doesn't capture what macrophages are doing at the cellular interface. Because macrophages aren't just releasing signals into the extracellular space, the space around all the cells, they're making direct physical contact with injured muscle fibers, They're forming structures that look like neuronal synapses, and they're driving electrical activity in those fibers in real time. The specific marker the researchers found at the macrophage myofiber contact site is PSD95, postsynaptic density protein 95. If that name is familiar, it's because PSD95 is a scaffolding protein that normally lives at neuronal synapses. It organizes the postsynaptic machinery at sites of electrochemical communication between neurons. Finding it at the macrophage myofiber junction tells you that this contact is not incidental. The cell is building a specialized communication structure, and that structure's job is to drive calcium into the adjacent muscle fiber. So, what we normally see in the M1 is an immune cell arrives at an injury site, builds something, but now then it shifts to an M2 and it builds something that looks like a synapse, right? Like it's a nerve connected to another nerve. But in this case, it's a immune cell connected to a muscle fiber. And then literally pumps electricity into the muscle through calcium ions. But
That's
not what
amazing, actually, because I wondered how that happened, how
yeah,
that new muscle fiber, how it actually can function with the already set nervous system the way it does, because we see it happen all the time in patients, but I just
right.
never knew that's how it did it.
Yeah, you didn't realize, I didn't realize it was driven this way. Like, oh, okay. So it's electrically driven. The macrophage comes in and literally uh, reboots the muscle fiber and says, let's start over. Let's do this. Let's build here. Let's get going. And that's, because that's not the way any of us learned it. But this is what the tissue is actually doing. And once you see it, you cannot look at the macrophage's role in healing the same way again. Okay, so calcium is the message. Calcium keeps showing up across every system we discuss in OsteoSignal, and it's worth understanding why it works as a universal signal. Cells maintain an extremely low intracellular calcium concentration at rest, around 100 nanomolars. The extracellular concentration is around 2 millimolars, right? So pretty big difference. That is a 20,000-fold gradient. When a channel opens and calcium floods in, the cell knows something happened. The signal to noise ratio is extraordinary. Calcium is one of the few molecules in biology that can carry that kind of information precision, right? Typically, chemistry in the body, in the world, is somewhat messy. And in this situation, it's very precise. But in muscle, the connection between calcium and repair is direct. When intracellular calcium rises at a site of membrane damage, a protein called dysferlin, think of it as the membrane repair machinery of the muscle cell, fuses vesicles, little bags, to the damaged area and patches the hole so that the cell contents don't leak out and kill the cell. This is the first line of defense against mechanical injury at the myofiber level. Calcium also drives satellite cell activation, satellite cells being the stem cells of muscle, the quiescent cells that sit between the fiber membrane and the basement membrane and spring into action when a fiber is damaged, proliferating and fusing to contribute new myonuclei and support regeneration. Now, myonuclei are the nuclei of muscles, and interestingly, muscle cells look like many cells fused together because they can have many nuclei, whereas normally a cell only has one nucleus, which is where the DNA is stored, and RNA is transcribed to tell tell the cell which proteins should be made. Okay, so muscle cells are a little bit odd that way. Okay, here's the piece that reframes everything. What the macrophage synapse is doing is delivering calcium to exactly the right place at exactly the right time in a localized, targeted way. So unlike being a janitor, it's more being the electrician or the high-tech maintenance guy that comes in and plugs his computer in to your mainframe and goes, oh, I see the problem, and starts moving signals around and fixes it. It's not broadcasting. It's not using a diffuse cloud of signal and hoping some of it reaches the right receptor. It is literally plugged directly into the fiber at the injury site, driving a precise calcium transient, right, or gradation, and triggering a precise repair response. This is precision signaling at the cellular scale. Pretty amazing, actually. In OsteoSignal terms, a bioelectrical event, the calcium transient, is the bridge between immune contact and biochemical repair. The immune system and the body's electrical signaling apparatus are not separate departments. They are speaking the same language at the same junction at the same moment.
That is fascinating because as you're treating patients, for example, that have had just an acute injury or recent surgery, that kind of thing, you can feel that hot damaged tissue that's like, oh, it's like a fresh thing, and the body's calling all that stuff into there. That immune system's going, and then as they start to heal, you can feel it getting that different texture, that different response, and it's you can actually palpate that. That's amazing.
Exactly so. I mean, it really tells you some of what it is we're feeling under our hands when we do work on damaged tissue like this. Okay, so let's follow this through a patient. So a patient came to me, a runner, early 40s, a hamstring strain from 7 months earlier. Not a serious injury in imaging, right? No structural tear, no reason it shouldn't have resolved in about 6 to 8 weeks as normal. But 7 months into it, the muscle was still dense and reactive under my hand. Range of motion was still limited, and every time she tried to return to full training, she'd flare within 2 sessions. Her imaging looked very clean. Her pain wasn't debilitating, but the tissue just wasn't healing. And of course, we went through the normal things. The classical explanation would reach for re-injury or for central sensitization or for psychological contributors, right? And medicine always likes to blame the patient, right? That's just it's easy to do. It's like when you lost your keys, you swear somebody stole them. um, and those things can still be playing a role. That's not what I'm saying. But what the macrophage myofiber research points toward is a more mechanical explanation that I think gets missed constantly in chronic injury cases. I have other physical therapists, there are other people in our field who they look at what we say we're doing and they're saying, oh, it's voodoo, it's magic. And here exactly is how it's not magic. Here is exactly how it is exactly what we're saying it is, that we're directing healing at the cellular level. I mean, and this is exactly another one of those we've talked about mechanotransduction, but here's another way that what we do helps focus healing at the cellular level. Okay. So if the mechanical environment of the tissue is disrupted and stays disrupted, if fascial restriction persists around the injury site, if load transfer through the region stays abnormal, if the interstitial fluid dynamics remain impaired, then macrophage trafficking to the injury site remains compromised. The immune cells can't get where they need to go efficiently. And even when they do arrive, the mechanical instability of the tissue environment disrupts the stable cell to cell contacts needed for that synaptic coupling we just described. What you get is a smoldering M1 dominant state, right? You still have macrophages in the M1 state coming in and trying to clear out debris. So the debris clearing phase extends indefinitely. Inflammatory cytokines persist. The tissue keeps getting signaled to destroy rather than to rebuild. And here's the self reinforcing part: chronic inflammation stiffens the extracellular matrix. Fibronectin and collagen crosslinks increase, more so than they should. The mechanical environment becomes more restricted, which further impairs macrophage trafficking, which perpetrates the inflammatory state, which stiffens the tissue further. That's the loop, right? And it goes over and over and over until there's some intervention in there to get it to change. Now, in her case, this patient's case, the palpatory picture was consistent: dense, reactive hamstring tissue with poor regional fluid dynamics and a thoracolumbar junction that was contributing to altered load transfer through the posterior chain, right? Her postural relationships were off, upper body, lower body. The intervention was mechanical. We restored the lumbopelvic mechanics, addressed the fascial restriction around the injury region, and reintroduced progressive hamstring loading in a way that was sequenced to support rather than disrupt the repair phase. By week 6, the tissue quality under the hand, under my hand, had changed substantially. By week 10, she was running again without flaring. The tissue hadn't failed to heal because something was wrong with her healing system. The mechanical environment had trapped her healing system in the wrong phase, and it couldn't transition out of the M1 phase and into the M2 phase, the healing phase. And that's really, that's part of the manual therapy that making all those other areas move so that there's not excessive pressure placed in that area. Then the lack of excessive pressure in that area allowed her to transition from an M1, tear it down, you know, uh, throw out the trash phase into a let's rebuild this, let's get the right nutrients in here, let's connect into those muscle fibers, those myofibers, and regrow them and reboot them.
Well, and what you did worked in about the same time frame that you'd expected a hamstring to heal. It was starting to follow the normal pattern after that
Right.
intervention was made. That's awesome. That's so cool
Well,
that we can do that.
Exactly. I mean, and there's the thing is, we've all had these patients who've had hamstring tears like this that have gone on for years, and then they finally come in to see us, and of course, we get them working again, and they're like, I don't understand. That was amazing. Why didn't anybody do that? And it's like, well, you have to treat at the cellular level. You have to understand the machinery of what it is you're working on.
Yeah. It's kind of like it gives you a second chance to treat it right from the beginning or to heal right from the beginning, you know?
Exactly. Yeah, we get to start it over. Okay. So what we can do, the OsteoSignal healing loop. Let's talk about it a little more because Autumn and I want to talk about this. Uh, so let me lay out the complete healing loop that this research is describing, because this is where the OsteoSignal model and this science converge into something clinically actionable. It starts with a mechanical disruption. Injury alters the tissue architecture. That immediately triggers immune cell recruitment through damage associated molecular patterns. The, the DAMP alarm signal, as we call it. So, damage associated molecular patterns. Macrophages arrive at the injury site, and here's the step the classical model skips. They don't just release cytokines, they adhere to the injured fiber. They form a PSD95 associated synaptic junction. In other words, the macrophage is acting like a neuron, hooking into the muscle, kind of like neuron to muscle, neuron to neuron. It really shows you that these immune cells are neurons, really, right? That they are uh, neural crest derived tissue, and then they maintain that ability. So then, of course, the macrophage starts pumping in calcium, and that calcium activates dysferlin mediated membrane repair. It triggers satellite cell activation and initiates myofiber regeneration. Structural repair follows. We've gone into M2. And as structure is restored, normal mechanics return, which creates the conditions for ongoing healthy immune signaling, which means that the muscle fibers integrate their actions. They get stronger. They are able to take more force. They don't they don't increase inflammation or local inflammation. So let's cover that. Mechanical disruption, immune recruitment, synaptic coupling, bioelectrical activation, structural repair, restored motion. And then restored motion maintains the conditions that allow the loop to keep running and improving function. Every manual therapy technique is entering this loop at the mechanical entry point. When you restore accessory joint motion, you're improving the fluid dynamics that allow macrophages to traffic to the injury site. Whether you're doing myofascial right at the site of the tear, whether you're affecting those joints above and below, or even regionally, right, or globally. For example, making sure that the occipital atlantal joint works properly, that the person's balance mechanism functions properly, so that they have the appropriate amount of trunk torsion left and right, so that they're not just putting all their pressure onto that torn hamstring. When you release a fascial restriction, you're removing the mechanical instability that disrupts stable macrophage myofiber contact. And when you normalize load transfer, you're contributing to the piezo-1 mediated calcium signals that speak the same biological language as the repair calcium signals the macrophages are generating, right? Notice that these signals are the same wherever you go in the body. The body has certain ways that it handles things. And it's our job to connect into those and magnify their ability to occur. And you're not fixing tissue like a mechanic. You are restoring the conditions that allow the body's own precision immune electrical repair system to function. That is a totally different framework, and it leads to different clinical decisions.
Yeah, and I like this too because it helps us be able to communicate better with our patients when we can describe really what's happening and say, "Hey, it's not that you're crazy or that it's your fault that somehow it's still in pain. It's because these things are happening." And then they can better anticipate as we work through that treatment how their body's going to heal and get rid of that pain.
Right. So true. And it really changes how we speak to a patient. Patients get very frustrated that they're not making uh, they're not making progress. And of course, you constantly get that. Well, the doctor said I'm old, or I'm society said I'm old, or I guess I'll never be able to run again. Which is every runner comes in. I'll never run again. My life is over. No, we'll get in there. We'll make it. We'll remove the barriers to healing and let the system take over. Yeah, and
But
yeah,
the fact that the pain system and the healing system are different is also like a huge key to that.
exactly. So, and that's the part of this research I find most important for patient conversations, right? And I want to make it explicit. Repair and pain can be completely dissociated because people have the pain and think that's it. It's not going to ever be better. In the study, macrophage activation accelerated membrane repair and regeneration in certain injury models without changing pain behaviors. Repair happened. Pain didn't necessarily follow. Um, and that's the whole thing, is that, the thing that's causing the pain is the fact that that area is not healing. It's stuck in an M1 situation. There's chronic inflammation there. You go out and exercise it, and that just expands the amount of inflammation that's going on. Okay. In this situation, it stops expanding. And so it completely dissociates the pain problem from the repair situation. So, and that, that's not a failure. It's how biology works, right? So chronic pain is a nervous system output. It is the brain's best prediction, given all available input, that the body is in danger. It's a security system, not a damage meter. So the absence of pain reduction after a treatment session does not mean the treatment didn't work. Tissue may be repairing, and it's going to take time, right? It doesn't always, I mean, there's some things we do and they're just amazing, and boom, pain's gone. But that's not necessarily what this is. The immune electrical signaling may be optimized. Macrophage myofiber coupling may be occurring, and the patient's pain experience may not reflect that yet, because the nociceptive system has its own timeline and its own central sensitization patterns. Certainly, neurological systems, your neurology learns to be in pain, because it becomes this, hey, be careful. Oh, look out. Don't do that. Ooh, that's going to hurt. That's going to hurt. And it's a little, how does the body protect you further out? It can't wait until you do something to say, well, you shouldn't have done that. It more wants to tell you ahead of time, don't do that. And there's some working through that, right? I mean, and that's part of it. But that's part of giving, the normal rehab stuff of, like, do some mild stretching, sit on the ball there, start walking, start doing this, start doing that. Yeah, get back to your activities. Yes, you can start to run. It's going to hurt a little bit. That'll be fine, unless it hits that big spike, right? I mean, all the same things we always tell patients. So, and I just thought this was such an important thing to bring in. So macrophages form synapses with injured muscle fibers. That's the big takeaway. They plug in electrically and drive the calcium signal that initiates repair. Motion heals because it governs the mechanical environment in which that immune electrical coupling happens. Restore the motion, restore the loop. And then that loop will take over. I mean, our job is not to heal the body, right? And for a lot of patients, they think, oh, we gotta do something that's going to heal it. And, like, for example, the idea of surgery is going to go in, it's going to heal the joint. No. I think one of the biggest effects of surgery and some of the medical interventions is that it completely tears the place up, kicking off an even bigger inflammatory cascade, which sometimes is so big that it allows that lower level of the inflammatory problem to just be blown out of there, and the whole system can then start over and go to the M2 and rebuild, right? But wouldn't it be even better if we didn't do the extra damage, but that we just went through that with our hands, right? And did it in a closed system. So restore the motion, restore the loop, right? And that's a mechanistic account of why what we do works, not motion is good for you as a principle, a step-by-step biological explanation of how mechanical input through immune electrical coupling drives the cellular events that restore tissue integrity. And when we restore motion, and in motion in a lot of ways, not just joint motion, tissue motion. I tell people all the time, like, I'll be releasing their quadriceps and I'll let them know, like, that these muscles are supposed to slide over the top of this bone. They're not supposed to be adhered down to it. And people are like, oh, there's a reason that the muscles attached to the top and the bottom. It's not supposed to be attached to the middle. Otherwise, that defeats how efficient the muscle can function. Exactly the same thing here. By taking all those restrictions out, and restrictions that people won't even understand or know because they don't know the anatomy or the physiology in that way. When we do those things, this is exactly what we allow to happen, because now fluid can be driven through the area. And that's something that, most treatments do not take into account, is how do you drive fluid from the ankle and knee through the leg, up through the hip, and up through the diaphragm. Otherwise, that hip or knee or whatever it is will not get better. That quadricep strain, that hamstring pull, but you have to have the appropriate motion at the hip, the pelvis, the knee, foot, ankle, diaphragm, mid-thoracic, forward posture, that forward, the anterior posterior posture, as we call it, or forward backward posture, side to side posture, rotatory, translational posture. If people can't go through that, especially think of the translation and the rotation, forward and backward, side to side, and rotation that have to occur for running. And that's exactly it. This patient didn't have those. And so all the force was going right back at that hamstring. And so it couldn't go from M1 to M2. We take care of all those other things. We address the local tissue. We integrate this loop and we're back off to healing. And there we are. So patients who understand this engage differently. They understand why you're working on something that doesn't obviously feel related to their pain. And that's really hard because most patients go, no. Didn't I tell you the pain is right in this hamstring here? Why didn't you put your elbow in it like everybody else? Or why didn't you give me a stretcher exercise that happened right here at my pain? Some of our patients
But everybody
understand
did that before we got them. So,
right.
We're not just going to do it harder and longer and somehow it'll work.
Exactly. If everybody else has tried that 10,000 times, why would we even try it? We already know it doesn't work. It's not that they're bad at doing it. Like, I've got a better elbow. Yeah. No, that's not what I have a better brain. So
now people come in and they're like, my head hurts. So I know you're going to wiggle my toe somewhere. And they just sit down and lay down. And, okay, here you go.
Whatever. Let me know what you're going to do. Yeah. And these patients, they understand why the goal isn't pain reduction in isolation. They understand why progressive loading and treating all these other areas, even when it's uncomfortable, is all part of the biology, all part of the physiology. The science to prove that manual therapy is simultaneously a mechanical, bioelectrical, and immune intervention is no longer theoretical. It's sitting right there at the macrophage myofiber junction. I'm Neal O'Neill, joined by Autumn Mayberry and Brent Mayberry, and this is OsteoSignal. Until next time, keep understanding the signals.
Thanks, Neal.
Thanks, Neal.
Thanks, guys. Thanks for being here.
Thanks for joining us for this episode of OsteoSignal. For more information, visit pursuitpt.com or pursuitperformancetraining.com. Want to show your support for the podcast? Like this episode, hit that follow or subscribe button, and leave us a comment or review. Remember, this podcast is for informational purposes only. Please consult your healthcare provider regarding any medical procedure. Copyright 2026, Neal O'Neill, PT.